In clinical settings today, severe depression affects up to 85% of all patients suffering from chronic pain. The standard framework used to understand this connection is the biopsychosocial model. It posits that physical pain and psychological states operate in a cyclical bidirectional loop, where each continuously influences and amplifies the other. Yet, a crucial piece of this model has remained elusive. While we map the psychological feedback loops, we have lacked highly specific, localized biological correlates to show exactly where and how this cycle physically manifests within the human body. The mind-body connection in pain management is widely accepted, but finding the precise structural and mechanical link, the actual tissue holding that distress, has remained a persistent gap in clinical practice. A 2024 observational study set out to find this structural correlate by examining the cervical myofascial continuum. The myofascial continuum is a three-dimensional network of connective tissue that envelops and penetrates muscles, bones, and nerves. The researchers pinpointed one exact anatomical target: the deep fascial layers of the trapezius muscle, formerly denoted as the M. trapezius. Their hypothesis was straightforward. The comorbidity of major depressive disorder and chronic neck pain should correspond to quantifiable structural alterations in this specific deep connective tissue. To test this, they examined 4 precise biomechanical variables of the fascia: its overall thickness, its stiffness, its resting tissue tone, and finally, its elasticity. By measuring these variables, the researchers aimed to prove that mental state and chronic pain leave a measurable physical footprint directly in the deep connective tissue of the neck. The study recruited a clinical group of 56 patients. Each individual exhibited moderate to severe depression, scoring a 10 or above on the PHQ-9. The PHQ-9 is a standard self-report questionnaire used to assess the severity of depressive symptoms. These patients also required a documented history of chronic neck pain persisting for over 3 months. This diagram displays the opposing control group: 56 healthy individuals presenting 0 depression symptoms, indicated by a PHQ-9 score of 3 or below, and absolutely no neck pain, scoring a 0 on the visual analog scale. The visual analog scale is a standardized psychometric response instrument used to measure subjective pain intensity. To ensure accuracy, the researchers enforced a strict demographic matching process. Each pair of participants between the 2 groups allowed only minor deviations in age, body mass index, and gender. By perfectly matching the cohorts and comparing the dual diagnosis condition against a pure baseline, any observed structural deviations in the fascia are directly linked to the pathology itself. The researchers utilized a high-frequency linear ultrasound device to capture precise thickness measurements of the trapezius fascia. The imaging isolated 3 specific anatomical measurement sites: the central upper deep fascia, or MTCUD, the central lower deep fascia, MTCLD, and the deep fascial layers at the origin of the muscle, MTO. This resulting bar chart shows a clear divergence. Across the measured zones, the clinical group exhibited significantly thicker fascial layers than the healthy control group. The data becomes exceptionally stark in the lower deep fascia and the muscle origin. In these regions, the structural thickening reached statistical significance, with a p-value of less than 0.001. The localization of these findings suggests that depression-associated neck pain drives specific structural thickening at mechanical anchor points, distinct from generalized tissue inflammation. Beyond structural thickness, the study evaluated the dynamic biomechanical properties of the fascia using a tissue compliance meter called a Myoton Pro. The Myoton Pro is a wireless, non-invasive device that applies brief mechanical impulses to tissue to calculate its exact mechanical properties. In this clinical context, stiffness is defined as the tissue's physical resistance to deformation. Conversely, elasticity is defined as the tissue's ability to restore its original shape after that deformation occurs. This data table illustrates the findings from the Myoton Pro device. The clinical group exhibited measurably higher resting tone and elevated stiffness across the trapezius. But the data contains a paradox. Despite the marked increase in stiffness, the elasticity values showed no statistically significant difference between the 2 groups. The tissue becomes significantly harder to deform, but its basal ability to rebound remains intact. This directly challenges previous assumptions that chronic pain results in total tissue degradation. Why do stiffness and tone increase while elasticity remains stable? The researchers propose that psychological stress alters a patient's movement patterns and posture, subjecting the cervical fascia to continuous mechanical stress over time. To survive this constant strain, the fascia adapts. It increases its rigidity as a compensatory defense mechanism to enhance cervical stability. Meanwhile, the underlying elastin fibers, which dictate the tissue's ability to bounce back, are relatively unaffected by this specific protective thickening process. This scatter plot visualizes the exact correlation between the two conditions. It maps rising PHQ-9 depression scores against the measured thickness of the left central lower deep fascia. The trajectory is clear. As a patient's depression score scales higher, the structural thickness of their left central lower deep fascia increases in tandem. The stable elasticity metrics identify these fascial changes as an active mechanical defense mechanism against psychophysiological stress. With these physical measurements, we can now update the biopsychosocial model with exact structural mechanics. This flowchart models how the cycle initiates. Psychological distress triggers altered posture, which forces immediate and prolonged mechanical stress onto the trapezius. This mechanical stress directly produces the study's key findings: localized fascial thickening and heightened stiffness. This amplifies nociception, registering as pain. Nociception is the sensory nervous system's physical response to harmful or potentially harmful stimuli. Finally, this heightened pain and restricted movement deepens the initial psychological distress, trapping the patient in a continuous, self-reinforcing loop. The myofascial continuum acts as a structural participant that actively perpetuates the cycle of depression. This structural reality creates a clinical imperative for bidirectional treatment. Physical therapies targeting fascial stiffness, such as targeted myofascial release, can serve as physical entry points to disrupt the psychological loop. However, this observational study is cross-sectional. It establishes a strict correlation between mental state and physical thickness, but cannot definitively prove the causal direction. The scientific mandate now requires longitudinal studies to observe these patients over extended periods. Researchers need to test whether standalone psychological interventions can physically reverse this documented fascial thickening over time. Treating chronic neck pain and depression requires addressing the entire cycle. The mind cannot be fully healed if the body remains